Here we go. All right, so we are on. So welcome again to our evening, and we're very fortunate this evening to have Dr. Jonathan Leventhal with us, and just going to tell you a little bit about him, give him a little bit of background. Jonathan is an assistant professor of dermatology, associate residency program director, and the director of Onco Dermatology Clinic at Yale School of Medicine. He earned his bachelor's degree at the Newark University and attended NYU School of Medicine, where he was awarded the Samuel Spiegel Award for Excellence in Academic Achievement and was nominated to the Alpha Omega Alpha Honor Society. Jonathan completed his medicine internship at NYU Winthrop Hospital and then attended Yale School of Medicine for dermatology residency training, where he served as a chief resident and received the Hugh L. Dwyer Memorial Fund Award for clinical excellence. As a faculty member, Jonathan is actively involved in resident education and completed the medical education fellowship at the Yale Teaching and Learning Center. His clinical interests include complex medical dermatology and onco-dermatology. Jonathan is the editor of the textbook Self-Assessment in Dermatology and associate editor of Dermatology 5th edition. He serves as the treasurer for the New England Dermatological Society and former young physician representative for the Women's Dermatologic Society. Make sure I've got everything. And so we welcome Dr. Leventhal.
Thank you. Thanks so much for having me, everybody. It's really a pleasure to be here and Zoom in from New Haven. I'm going to see if I can share my screen. Can you guys all see my slides? Yeah? Okay, good. And I think this is a really important topic, one that's obviously very dear to my heart as one of the few dermatologists in the country who actually have a practice in a cancer center, right? Because most dermatologists don't. Are in private offices or offices outside the hospital. I take care of a lot of patients with cancer, those who are battling cancer, those who are survivors, and I know firsthand from treating my patients how important these topics are, and they often aren't at the forefront of the medical care, because really the oncologists are focused on treating the cancer, but a lot of things can come up. And what I think I'll do is I'll introduce you to the field and some of the more common conditions that I see. I'll show a few pictures. I try not to include any that were too gruesome. So hopefully you won't lose your appetite for dinner. And then I think afterwards, I'm sure this is a very engaged group. I'm sure there'll be a lot of questions and I'll be happy to tackle them. All righty. So I'm gonna get started. And
I've seen it. Good movie.
Okay, good. And dermatology, as I was mentioning, is really important for cancer patients. The reason is basically every type of cancer therapy that we have can impact the skin, the hair, the nails, and the mucous membranes. Every type of cancer treatment, whether it's different chemotherapies, the old chemos, the new. Sorry, is that a?
Yeah, you know what? You please mute yourselves, guys, please. I know that I think people are unmuted. We want to make sure that you're all muted, please. Okay, I think we're
okay.
good.
I'm good. All right, thanks. I know Zoom. It's always fun. Yeah, it's always a challenge. There was no toilets flushing, so that was good. I'm just kidding. We see a lot of that at Yale on our calls, so that happens everywhere. Yeah, so as I was saying, many different types of chemo can cause it. Even the newer targeted and immune therapies, they especially have side effects that impact the skin, hair, nails. Radiation treatments and stem cell transplants for those who have hematologic cancers. And this is actually validated. Studies have shown that these types of adverse effects impact patients' quality of life. So not just the physical domain by causing itching and pain and discomfort, but also the emotional domain as well. And so these are important. They should be addressed and really, I think, in my opinion, are part of the overall care of cancer patients. I think it's really important. One of the things that I try to do is I try to empower my patients with knowledge of what to expect and of tips that they can do to try to prevent some of these toxicities, and also tips on how we can treat them. Sometimes the treatments are over-the-counter remedies, and sometimes the treatments are prescription. And fortunately, most patients were able to treat their conditions and they're able to stay on their cancer therapy. So that's why I think it's really important to address it. And as I said, that studies have shown by involving dermatologists, both in the outpatient and the inpatient setting, it improves quality of life, and patients might be more likely to stay on their cancer treatment. Many different rashes can happen from chemotherapy and targeted therapy and immunotherapy. Some of the rashes are really itchy and can affect the whole body. These are more of like the allergic type of rash. We still see a lot of these from targeted and checkpoint inhibitor therapies and even the traditional chemos. Some of the rashes in particular affect the hands and the feet, and you can get painful red rashes and even blisters. This is true for a lot of the taxanes, adriamycin, cyclophosphamide, and even the new tyrosine kinase inhibitors can give you these types of rashes. And a lot of my patients get these acne type of rash or folliculitis when they're on targeted therapies for a number of cancers, including lung, head and neck, breast cancer, colon cancer. And a lot of these rashes develop in those patients. In some medicines, actually 80% of patients develop a rash. And so it really has a high prevalence. And the rashes can really be these allergic types to very severe blistering types. I see a lot of hair changes also. Many types of chemotherapy cause hair loss, as I'm sure a lot of you know. The traditional chemotherapies often result in near complete hair loss. Fortunately, the hair usually grows back slowly, but I do have a lot of patients, as you can see here on the right, that have, even after finishing chemo, persistent hair loss. And this is a side effect that we know can happen. Not all hair loss is fully reversible. I think about a third of patients who are on a taxane might have persistent thinning even after all the hair grows back. And what's really interesting, sometimes the hair grows back different. It grows back curlier, the texture is different, the color is different. It used to be dark, now it's lighter gray. A lot of my patients tell me that. And not just hair on the head, also eyebrows, eyelashes, really all the hair can change. Now, we didn't really have much we could do to prevent the hair loss. But most recently, you may have heard that, especially this is popular for my breast cancer patients, there's something called scalp cooling when you basically localize cryotherapy. So kind of like it's this cap that has like frozen ice, and it basically freezes the scalp, the skin of the scalp, so the chemo doesn't get there, and it helps to reduce hair loss. At this time, it's not covered by insurance yet, I believe, so it can be a little bit cost prohibitive, but there's lots of groups out there advocating for patients to have this coverage. So lots of hair changes from chemotherapy. Also, lots and lots of nail changes. So when people think of dermatology, it's not just the skin. The hair and the nails are really important. A lot of my patients who are on traditional chemotherapy like taxanes or the newer targeted therapies have nail changes. They get nail infections, as you can see, with these painful granulating lesions there and ingrown nails. They also have the nail plate lifts up and there can be bleeding and pus develop underneath it. A lot of my patients with breast cancer and gynecologic cancers report this when they're on taxanes. And these nail changes really impact quality of life, not just the appearance of it, which is very important, but also the ability to work and to do things because they can be quite painful. So fortunately, we have lots of treatments that we use to tackle these nail changes. I can discuss some of that later, but they're really important to consider as well. And so I wanted to keep the presentation short, just a few more slides. I just wanted to talk about some tips that I discuss with my patients who are both undergoing cancer as well as survivors of cancer, because an important point is a lot of the skin changes persist. Chemo can change your skin forever. Your skin can be dry, flaky, prone to eczema, prone to cracks. And so I really believe that having gentle skincare and promoting your skin health is important. So I tell all my patients that they really need to be careful in the sun. I happen to love the sun, I love the beach, but you won't see me without a hat and you won't see me there without sunscreen. And SPF 30 or above and reapplying it every few hours, really important. Reapply it after you sweat, reapply it after you go in the water. I always tell patients not to buy ones that have fragrances and all these fancy chemicals. Just stick to, either a zinc oxide type of thing, which a lot of people don't like because it's very white and pasty, or another type, but really try to get products that don't have fragrances or other harsh chemicals. Moisturize, moisturize, moisturize. Really important. So many of my cancer patients have dry skin, eczema. The winter's a really tough time for a lot of my patients who were on chemo or currently are. So when it comes to moisturizers, a lot of people don't realize that ointments and creams are better than lotions. Lotions have some more alcohol in them. And so the best moisturizers for those dry, cracked hands in the winter would be something really greasy, like Aquaphor or Vaseline, and you put on cotton gloves or socks on top. I mean, that can be really helpful. For the body, it's a little tough putting Vaseline all over. It'll stick to your clothes, your sheets, your couch. But other moisturizers, and really, there's not one brand that I recommend. I think a lot of them are great. CeraVe, Cetaphil, Eucerin, Aveeno, Neutrogena. I mean, there's so many great brands. You don't have to buy anything fancy. All those name products are fine. I really like the ones that don't have extra fragrances. They make some that are really good for dry skin and eczema, and that says it on many of the bottles. And I think those are really good ones to use. Moisturize after you shower, moisturize a few times a day. Speaking of showering, when I talk to my patients about their favorite soaps, I sometimes get answers like Ivory Spring or Irish. What's the other one? The green one? You know what I'm talking about?
Irish Spring.
Yeah, Irish Spring and Ivory. I mean, those soaps are so harsh for your skin. They really dry out your skin. They smell great, and I'm sure they work well as antibacterial. But I tell my patients, you really try to find a soap that is a gentle soap. They make soap-free cleansers, which cleanse your skin but don't have the harsh soaps. Those are great for your face. Cetaphil has a nice cleanser. I think avoiding harsh soaps is really important. And, in dermatology, when patients have bad eczema, we often say, don't even use soap on the skin with eczema. Just use soap on your underarms, your groin, anywhere, your feet, areas that you think might actually need it. And then just have the water, rinse on your skin, because soaps are very drying. What also is very drying, and a lot of people like this, are really hot baths, hot showers. I know they feel good. Everyone likes to go on a nice hot tub sometimes, but hot water is really drying for your skin. So I do tell my patients to try to avoid the really hot baths. I also tell my patients who are on treatment, or even after treatment, especially those who are very active. A lot of my patients are very active. They're runners. They use their hands. They're mechanics. They're plumbers. They like to knit. They like to do woodwork. All types of hobbies. All those things, all that trauma, repeated trauma, can really exacerbate a lot of the rashes, especially the ones that affect the hands and the feet. And so I'm always telling them, you got to protect your hands. You got to protect your feet. Fix socks when you run. Double layer socks. And for the hands, you should always wear gloves when you wash dishes. When you do things, woodwork, other things, always wear gloves, because that constant trauma really aggravates a lot of the skin rashes I see. And it turns out to be the case. And a lot of my patients come back and say, wow, I didn't realize, that part of my job is to do this. And now that I wear gloves, the hands are so much better. So that's really important. A lot of my female patients, although some of the males as well, but mostly the female patients who like to get manicures and pedicures always ask me, can I? And I never like to say you can't, but I do tell them, I don't want them to cut back your cuticles, because that can increase the risk of getting nail infections. And so you can get your nails painted with nail polish, but I don't let them cut back your cuticle, which makes the nails look nicer, right? When they cut back the cuticle, I'm told. And another thing is that a lot of the treatments for cancer, like radiation, for one example, which is used to treat many cancers, can increase your risk of skin cancer even years down the road. Now, this isn't to scare everybody who had radiation. The risk is still pretty low, and the type of skin cancers that form are usually the type that are pretty easy to treat, basal cells. They don't spread. However, it is important to see a dermatologist for any area that's changing, especially within an area of former radiation or just anywhere on your body. And so you always want to have a good dermatologist that you like seeing. And then the way that we treat the rash really depends on a number of things. It depends on the type of rash. It depends on the severity of the rash. Some rashes are quite mild, and we might just use moisturizers and things like that. And some of the rashes might require prescription strength steroid creams, which are very helpful for itching, or prescription strength antibiotic lotions, like if you have that acne type of rash. Some of the more severe cases, we even prescribe doxycycline antibiotics or cephalexin antibiotics that can help treat these skin infections, the nail infections I showed you. Many times patients say they really like the antiseptic soaks that I tell them about. So some things you can even do at home without having to even get a prescription. For those painful nails that have pus, vinegar soaks work great. And that's about, you could do a cup of white vinegar and a cup or two of water and soak. That works really well. A lot of my patients that are constantly getting boils and abscesses and pustules, they really do well with bleach baths, which you just use some Clorox at home, a half a cup, and you fill the bathtub up. And then you can take a bleach bath. That helps to clear all the bacteria. That works really well. So these are examples of things that we sometimes recommend to patients that aren't prescription. We very rarely have to treat rashes with prednisone. It does happen. There's some really tough blistering rashes that I see from immunotherapy and some really widespread itchy rashes that the creams aren't helping, and prednisone usually does. Another piece of the pie is that sometimes patients need a little bit of a break from the chemo that's causing the rash. And then usually the good news is when we restart the chemo, the rash is usually self-limited or doesn't come back, which is great. It's very rare that I've seen under my care a patient having to stop or change their chemo. Sometimes the dose gets a little lowered for them to tolerate side effects, but it's very rare with this type of care to have to change your chemo, which is great. And so most of the patients do improve. That's the bottom line. I think it's great working with oncologists. I feel at Yale Cancer Center like I'm part of the team. They call me, they run things by me. We put our heads together, and it's just nice to be part of that team. So that's kind of what the field of oncodermatology is about. And I don't want to give you too much information because it could be overload. I'll take any questions you guys have. You're on mute. I can't hear you.
So you know what? If you stop screen sharing, then we can. You'll be able to see everybody, and we can.
Oh, okay, great.
Perfect.
Oh, I already got lots of questions. Okay.
Yes, you do. We have lots of questions in the chat. So Jen and I will help field some of these for you, unless you can you see them already?
Yeah, let me just tackle them one by one. Okay.
Excellent.
I'm a New Yorker. I can just,
Jen and I are pretty fast paced, but I think you have us beat, Jonathan.
Get rattled. I love it.
My 6-month chemo ended and my nails still look like those. That's a great point. Nails grow 0.1 millimeter a day. They grow so slow. It takes 18 months for the entire toenail to grow out and about 12 to 14 months for the fingernails to grow out. So have no fear. It takes a long time. Nail changes will grow out. But so the fact that it's been so many years and it hasn't grown out means that you may have had, in addition to those nail changes, something else going on. It could be that maybe you had some fungus develop in the nails. Sometimes there's a bacteria that develops in the nails. And because they usually grow out within a year and a half to 2. So if it's been more than that, there might be something else going on, Margaret. And I think that seeing a dermatologist to take a look at it, do a clipping, offer some advice is good. Now, it is true, some nail changes are permanent. It's rare. I don't know if Margaret, if you're in that category, but it is possible. Next question. Ouch, sorry to hear that, Margaret. Oh, okay. What about aloe? I like aloe. I think aloe is a great over-the-counter soothing moisturizer to use. I would just be careful that it's not one of the ones mixed with a lot of other things that have fragrances and alcohol base. But what I tell my patients when they ask me which moisturizer, I always answer, I never give them a name. I always say whichever one you will use and like. So if you like the aloe, that's great. Coconut oil is really popular. I'll tell you, I have a tea tree, coconut oil. I think these oils can be good moisturizers. I think they can be good when you have the flaking scale in your scalp. I will say there's a very low risk of being allergic to it. You get these allergic contact dermatitis, but if you like the coconut oil, if it works for you, then it works for me. Shea butter is another one that people like. I like Dr. Teal's. So as I said, they are all okay as long as you like them, they work for you, they don't hurt your skin, and you're not allergic to them. As a licensed cosmetologist, I've dealt with many cancer patients. How can I learn to better serve the cancer community? Well, that's a really, really good question. I think that there is a lot of opportunity for cosmetologists and aesthetic care in cancer patients, because lots of changes, which I didn't discuss, can also happen to the skin. There can be darkening of the skin, in which like lightening creams and peels can help, or lasers. There can be scars. Lots of things can happen. I think my answer to you is to collaborate with oncologists, to make yourself known that you want to help and serve this community. When I first started, I think one of the best things I did to help my practice grow is I gave talks. I gave talks in the community. I gave talks to the nurse practitioners. I gave talks to the PAs. I gave talks to the oncologists and the radiation oncologists. I think you just have to spread the education and spread that you want to help and you are around. Okay, let's see. My bones hurt and a nice hot Epsom salt bath really helps. Love. So I mentioned the bleach baths. I like the Epsom salt baths. I think those are really good ones to take also. Some patients who have these rashes in their groin and their butt, they really like taking sitz baths, which can be very soothing. I'm a huge fan of all those baths and all of those antiseptics. How do I balance that out? Well, I'm not exactly sure what the balance out question is, but I think that.
I think it was the hot water, because you had said stay away from hot water.
Oh, okay. Yeah. So I understand. So I would say that try to make the water less hot, or if you can't, because you love those hot baths, then I would say to at least moisturize right afterwards so the skin doesn't dry out. That's my advice to you. I use HipaCleanse. I love HipaCleanse. HipaCleanse is like the bleach bath, but it's the antiseptic version of it. So if you don't have a bathtub, if you take a lot of showers, HipaCleanse is a great one that helps clear if you have bacteria on your skin. The thing with HipaCleanse and bleach baths and the hot baths, just moisturize after, because they can dry your skin a little bit too. I think that they serve a purpose as an antiseptic to kill bacteria and other infections, but you also want to moisturize. Can you address the accelerated aging from chemo? That's a good question. Chemo, a lot of my patients will say that after chemo, they found their skin to be very wrinkled, lots of sunspots, lots of bruising. Their skin is so fragile. All they do is they touch a doorknob and they get this big purple bruise. This is really tough because, as I said, I do think chemo causes permanent changes on your skin, hair, and nails. I do, to an extent. I think it's hard to say why. My advice is to just promote the healthy skin, avoid the sun so you're not going to get further wrinkles and sunspots. Lots of moisturizers to make your skin as strong as possible. And it's tough. We can't change people's skin. We can't remove, we can't do skin transplants really. But that's a great point, Darla. And then Jody, I'm having intense itching on my arms, started during chemo, now continuing with immunotherapy, really bad at night, and nothing topical seems to work. Okay. Could this be neuropathy related? So you know what? A lot of immune therapies cause itch and rash. I would say 50% total. And neuropathy is more so with the numbness and the tingling on the fingers and toes. But a lot of patients with itching from immune therapy, you believe it or not, would actually benefit from some medicines to treat neuropathy. So I have some patients that I prescribe for them, like a gabapentin or some prescription strength antihistamines, and that can help with the itching. There's a lot of pills for itching, and not every pill works for every patient. There's other things we can do, like light therapy. What's interesting about immune therapies, we see all these different rashes that mimic a rash that we already know about, like eczema. Immune therapy can mimic eczema rashes, psoriasis rashes. And so what we do is we treat the rash as we would ordinary eczema or psoriasis. And so I think if you have intense itching, I think that I would definitely see a dermatologist, one that's familiar with immune therapy, which I think most of us are now, because it's really gained access to all the big journals and all the big meetings, and everyone talks about it. And so I think you might need something prescription strength if none of the over-the-counters work for you. All right, Jody. And then Harriet, I've always had great facial skin. Suddenly last year, my cheeks are full of age spots. I think I touched upon this before, Harriet, how you can have accelerated skin aging. Okay, and we went there with my local hospital. Oh, cool, interesting. I just learned that all the bleach is not created equal, chlorine bleach or non-chlorine bleach. So good question. I usually just recommend the typical Clorox, which is the chlorinated one, and then it's so dilute that it's like less than a swimming pool. And so my patients who are worried about the Clorox burning their skin, it really won't. Another one with severe itching from immune therapy, I see a lot of this. I was on prednisone and recently was weaned off. Now the itching came back. It's taking prednisone bad for long periods of time and using therapy, the itch. Okay, so I see a lot of itching from immune therapy. It can be so stubborn and frustrating. I would say to you that prednisone is very helpful, but you're right. You don't want to stay on prednisone long-term because in a sense, if you're on high dose prednisone, it counteracts what the immune therapy does. If you're on low dose prednisone, it's probably okay, but you never want to be on prednisone for long periods of time if you can help it because of all the side effects from it. So you might be someone, Shirley, who might benefit a lot from prescription strength itch pills, at things like doxepin, hydroxyzine, gabapentin, some pills that actually might help the itch. You might benefit from the light box, which a lot of dermatologist offices have. You might benefit from injections that are used to treat itch and eczema, which we're now starting to use. So I think, Shirley, that you probably would benefit from a dermatologist weighing in as opposed to just giving you prednisone. I also get extremely itching. Yeah. So itch is a really common one that I see, guys. And I think the topical steroids are a place to start. You can always get over-the-counter hydrocortisone. You can always buy Sarna. Sarna's over the counter. A lot of people like Sarna as an anti-itch one. Another one over the counter is CeraVe anti-itch. I would say if you want to start with over the counter, start with hydrocortisone, start with Sarna, start with CeraVe, use it on your skin all the time, lots of moisturizer. You can always take like a Zyrtec over the counter for allergies. It's a very safe medicine. I really can't think of any reason why you couldn't take a Zyrtec. You could always start with that. And then if that doesn't help, then I think you should speak to a dermatologist because I think there's other things that we can do. Any tips on ingrown toenails? These are really tough. When it comes to ingrown, that can lead to those infections, those pictures I showed you. The vinegar soaks are really good to keep them clean so they don't get infected. I think with the ingrown, if it really is badly ingrown, my podiatry friends help with that. They often will help trim the nails or do a partial nail clipping so it's not piercing into the skin. I think my podiatrist isn't very cancer friendly. He doesn't really know of one. Gotcha. Yeah, I mean, it's tough. I think that for the ingrown, it's a problem that the nail is ingrowing into the skin. And sometimes you need a good podiatrist who knows how to do some sort of partial nail clipping or nail avulsion to help with that. But those ingrown nails can be stubborn also. Unfortunately, there's no like cream you put on the nail and then it's not ingrown anymore, so but those really respond well when podiatrists take care of my patients. They come back, they show me their nails, they're clipped so they're not growing into the skin. They're very happy. My dermatologist told me to take Allegra. CeraVe itching helps in the oatmeal bed. Yeah, I think Allegra is a great one. I like Allegra a lot for the mornings. I like Zyrtec a lot also. Some people get a little sleepy with Zyrtec. I actually do, but most people don't. So I think Allegra and Zyrtec are probably my two favorite antihistamines for the day. And then at nighttime, I think Benadryl helps. I think when it comes to itching, unfortunately, the regular dose of one pill in the morning isn't always enough. And I tell this to my patients with itching. It's, you never want to overdose on anything, but the truth is, if you were to take one Allegra in the morning and then one Zyrtec later and then one Benadryl at night, you would probably be fine. These antihistamines are very safe, and some of my patients need to take them a few times a day. And some of them even say on the prescription that you can take, a couple times a day. So I do think Allegra is a great one, and I like the CeraVe itching.
Anybody else? I know you all have had really great questions.
These are great questions, really good ones.
I have a question for you too, Dr. Leventhal. What I know you mentioned not the manicures and the pedicures, and what about like a gel pedicure? I know a lot of people get those. Are those okay still for people to have? That
those are the ones when they do like the UV light drying type thing. Is that the one?
Yes.
Yeah. So this has been a hot topic. People say, well, is the ultraviolet bad? Will it cause skin cancer of the nails? And it hasn't been proven. So I would say if you love those gels, if it makes your life happy, okay. But there is a potential theoretical risk that the ultraviolet used to dry them could potentially cause skin problems, but it hasn't been proven yet. So maybe it's not the case. Maybe it's perfectly fine. I think that I tell my patients when it comes to these manicures, pedicures, as long as they're not getting infected or doing anything that's going to make them sick, I'm fine with it.
Okay, that's great to hear.
So let's see a few more
Other
questions.
questions, yeah.
Nails are splitting vertically down low. It's driving me crazy. And it's, oh, okay, that's a good question. Any supplements? So yeah, there are some supplements that, the thing with supplements is they're often not scientifically validated. They're often not, often not studied, like randomized studies. It's often more anecdotal evidence, meaning people say it helped me, and then others say it would help me too. So I want to preface it by saying that this isn't really studied or approved, but a lot of my patients tell me they like to take Biosil, which is a collagen, and some of them like to take biotin over the counter. So I would say the vitamin B biotin and the collagen known as Biosil, Biosil, are supplements that a lot of people like. Supplements also for hair growth would be things like Rogaine over the counter. So a lot of my patients will do Rogaine when they think their hair is thin after chemo. It helps speed up the hair growth, and that actually has been studied. So that's a really good pearl. And then also Latisse, which you can put on your eyelashes to help them grow back. A lot of my patients like to use Latisse. It is a prescription. So Rogaine is a great one to know about. Latisse for the eyelashes, Biosil collagen, biotin vitamin. Nails get vertical, horizontal line. Yep, absolutely, Keith. The nails can get both vertical or horizontal lines, white bands, ridges, brittle, thinning at the top, hyperpigmented dark lines in them, lifting up. There's like a million different nail changes that can happen. What do you think of CBD products? That's a great question, Shirley. I think a lot of this is unknown at the time. Some of my patients really like CBD oils or other things like that. And I always have an open mind, and I say, if it's something that you think is helping and working, great. As long as it's not causing you any harm, any irritation, I'm all for it. I don't have good long-term data to support it though, Shirley. And then be careful with cancer and the soaks off with acetone. Yeah, that's true. Those acetone soaks are really very drying. That's a great point that I should have added to my gentle nail care, for sure. A lot of my patients also say for the nails, they like to put a hydrating lacquer on, one of those like clear lacquers that they put on their nails. And I think that's fine, a hydrating nail lacquer is fine. And I think that would be okay and not drying. But yeah, you got to be careful with the acetone for sure.
Mhm.
I've heard patients say that if they wear black nail polish through chemotherapy, I didn't personally do this, or if they a lot of people will use those mitts and socks, the ice mitten socks that will help with nail challenge.
Yeah, that's a great point. So the black nail polish, I don't think has any data. The frozen gloves and socks, which is similar to, remember the picture I showed you of the scalp guys with the frozen cold scalp cap? There's also these gloves you can buy. And if you don't want to buy the gloves, you can just put them in like a plastic bag and tie a rubber band around. And so, yeah, so cooling your hands and feet during chemo infusions on and off, not the whole time because you're going to get cold injury, but maybe like 10 minutes on, 10 minutes off type of thing can actually help prevent a lot of the hand, foot, and nail problems. And it's interesting because there's a little bit of data and studies showing that it works, but yet not every cancer hospital does it. I know for a fact. A lot of my patients don't get that. And I try to educate nurses that maybe they should. They're getting the hand, foot, and nail problems. Maybe they should hold the ice. And I think that it can be very helpful. Some of my patients say it's helpful. Others honestly come back and say it's very hard for them. The ice, having frozen hands is very tough. Sometimes the chemos they're on can actually give them susceptibility to being too cold, like cold intolerance. Like I think the platinums. So I think that's a good question for the oncologist, but I'm all for it. I'm all for the cold gloves and socks.
The other question that
Uh-oh. I think Jen just disappeared suddenly.
Oh, I lost Jen.
I know. She'll be back.
Okay.
Hopefully. Anybody else have any other questions? I know one of the other questions I have is for, women that are using, there's so many people younger and younger using like the Botoxes and all of the chemicals, right? Is there any risk for cancer, using any of those products at all? No.
It hasn't been shown. No, Botox seems to be just fine. It gets rid of wrinkles. It doesn't cause cancer, and just expensive. That's the big problem with Botox, and you got to get needles stuck in you every few months.
Yeah, and if that's something that when you're undergoing treatment, is that something still safe to have, even if somebody would want to do that? Or
Yeah, it's safe to have. I mean, honestly, most of my patients who are undergoing chemo, there's a lot going on. They don't want to run to have, 10 needles stuck in their forehead, they usually wait for the chemo to be over. The risk of infection with Botox is so little, they do stick little needles in, but it rarely gets infected. I think most of the time that they just wait till after, there's a lot going on with chemo already.
Okay.
Any advice for post skin? Yeah. So after radiation, man, radiation can do a lot to your skin. It can burn it as you're getting it, and then it can cause eczema and dermatitis. And then afterwards, the skin can become tight and discolored and hard with broken blood vessels. Really, we don't have anything great except lots and lots of moisturizers, steroid creams. If it's irritated, those seem to work really well. I think we don't have any pills yet for post-radiation changes. We've seen some really rare ones, especially on the breast, where the breast contracts and has like fibrosis from radiation. That can happen. That can be a tough side effect. Sometimes physical therapy helps. But I would say just all those things I mentioned about gentle skincare. Are you good with facials and scalp treatments when going through treatment? I get asked this question a lot, and it's similar to the Botox question. My answer to the patients are, if it makes them happy and feels healthy and it doesn't irritate their skin, okay. The problem with the facials is sometimes they do these like acid peels in addition to like poking out all of the clogged pores. And those acid peels can be a little bit irritating, especially when you're on certain types of chemos. So you really want to make sure you're using lots of moisturizer and things like that. But Leah, if it makes you happy, then and if it doesn't cause harm, that's my general rule, then I'm open-minded to it. No acid, just soothe. Okay, that's fine. Go for it.
Great.
I'm sorry, my battery died.
That's okay, we figured.
But a lot of problems that we see are the hand and foot disease with the Xeloda, and it's just horribly painful, and then some patients really can't even walk.
Yep.
What is any thoughts for that?
Yeah, so she's talking about, it's like the picture I showed you guys with like the foot that had a blister, except with Xeloda, it's more so the palms and the soles have these thick red plaques that are very painful. A lot of my patients who have that, I will prescribe for them high strength steroid ointments that they use with cotton gloves and cotton socks, so it really stays in. Some of my patients, for the pain, they will get like NSAIDs that, especially if they have no contraindication or reason why they can't get it. Some of those medicines help with some of the pain. We don't have anything great, honestly, besides those ointments and the treatment of pain. A lot of it's supportive care. And for Xeloda, it's a pill, I believe. And so you can't even do the frozen gloves, frozen socks.
Right. And yeah, and it's hard to reduce. I know some people have reduced the dosage, but even though that's hard. And then I did, some women have talked about, and I don't know if you talked about this with radiation, it's, and I'm not sure if I'm saying this right, metapitafilm. Am I saying that right? Are you familiar with it? It's like it's like a film that you put on yourself prior to radiation.
Oh yeah, is it kind of like a Mepilex thing? I think it's like a type of like biological dressing that you put on to your skin. So I would say with radiation, and a lot of my patients undergo radiation, during the radiation treatment itself, like after you get the radiation burning the skin, through the skin, putting on steroid creams later on at night can actually reduce the severity of the radiation dermatitis, the radiation burn. Studies have shown it. It will not cause any problems with it working, and it will help. Now, you don't want to put anything on before the radiation, like a cream, because the radiation has to get through the skin. You don't want to do anything to impact that. However, using steroid creams, cortisone creams, moisturizers at night, really helpful. Regarding that Mepilex thing, I'm not 100% sure if what you're saying is the one that I'm referring to, but I know that there's certain dressings that once the skin does burn and start to peel, that can be helpful at kind of coating the skin and protecting it. And so I would say those biological dressings, if your radiation oncologist is fine with it, could be helpful. The thing is, as I think you're all probably gathering, not one thing works for everybody. Everybody's skin is different. Everybody's skin reacts differently. Some people love one thing. Other people say, well, this worked much better for me. So I think that all of those are options that can work. Larynx cancer and mouthwash. Okay, so some patients who have head and neck cancers get radiation to the head and neck and chemotherapies, and they get a lot of what's called mucositis, inflammation of the mouth and sores in the mouth. And so this can be tricky also, but there's a lot of things that help mucositis. So when my patients have mucositis, a lot of them will use magic mouthwash with lidocaine. A lot of them will use topical steroids, swish and spits. Sometimes they have fungus infections and the tongue turns white, and then we'll treat that with a fungus suspension. There's really a lot of things. Pain management's really important with mucositis. It can be very painful. So there's some liquid things that patients can take, and other pain things. One study actually suggested putting ice chips in your mouth can actually help. And I don't think a lot of people do that. You'd have to ask your radiation doctor, but mucositis has a lot of treatments. Sjogren's of the eyes and mouth. Okay, so Sjogren's, I've seen Sjogren's from immune therapy. I'm assuming, Keith, maybe you had it as a side effect of immune therapy or something else. But for Sjogren's, there's lots of these. I'm not an eye expert, Keith, but I will say, talking to my ophthalmology friends about this, it's come up. Lots of those refresh tears and things. They often prescribe things when you have Sjogren's to help preserve the keeping the eyes nice and moist. And they also have things that you can buy to spray into your mouth to help generate saliva to keep it moist as well. So those are things that some of my patients with Sjogren's use. But I know Sjogren's can be really tough. Chemo and ADT, got it. I know Sjogren's can be really tough when your eyes and your mouth are very dry, for sure. Debbie's iPad. I use vitamin E every evening prior to radiation, have no burning issues. Good. Is it okay to use vitamin E after radiation? Yeah, vitamin E is another one. Like I said, some people like to use coconut oil. Some people like, as long as you're not, Debbie, reacting to it, vitamin E, a lot of people after surgery rub on, the vitamin E oil that says it helps scarring. I don't think it's been proven, but I think anecdotally, meaning people say it works, I believe. And I'd be fine with you using that if you like it. Good. I think I got everyone's questions right.
I think there's
another one there.
I just sent one.
Is there anything that would work? I've had it for about 8 months and tried many products. Yeah, it's tough. This is very similar to the Sjogren's question. Did you buy the things over the counter that you spray into your mouth that helps generate saliva? And that didn't help? Yeah.
Right now I'm on biotin
Mm-hmm.
and drinking lots of water.
Yeah, I think you're doing everything you can.
But it prevents you from eating.
I know. It can be very tough. It really can. Biotin's a good one. I like biotin. You could ask your doctor about some things that can help with it's like pain meds for the mouth that aren't like narcotics. They're like swishes and things. There's some things like topical doxepin that could sometimes help if you're having some pain and trouble eating. I know it can be tough, the dry mouth. We need better treatments for it. We do.
I have a suggestion for itchy. There's a product that I bought it at Amazon. It's called Bareback Scratcher. And it's this scratcher. It has a long handle on it. And whenever you scratch your back, it seems to make the itch go away.
Okay.
And I gave it to my, seriously, I gave it to my oncologist, Dr. Marks.
Yeah.
And he thinks it's great.
Hey.
It has a like a Teflon things instead of wood, but it does make the itch go away for a while.
I'll have to look that one up.
There's something in the scratching part of it, but it's called Barebacks. And they just come out, because I live alone and it's hard, to scratch around.
Mm-hmm.
They also come out with one that has a roller that you can put your ointment on and put it on.
Yeah, I like those applicators.
And Barebacks, I just got it today. It looks like a paint roller, but it has a long handle, and they just put one of those out too.
Yeah, those are great suggestions.
That's hard to do when you're by yourself.
That's a great suggestion. I totally agree. A lot of my patients ask me, what do I do? How do I get the cream on my back? I live alone. And I always, you got to get those applicators. There's a few different brands, just like the one you mentioned. It's like you put the cream on it and you put it right on.
Yeah, it rolls. But that bareback scratcher is like a miracle because
Good to know.
it just takes the itch away just long enough to get some relief. So.
Great questions. This is so informative, amazing. Anybody else have any other questions?
You can
Well,
always send them to Wendy or Jen, and then Jen or Wendy, you guys can email me a list and I'll just tackle them one by one, and then you can share it with the group.
We so appreciate you, because if we don't have, I don't think we do have that specialty here in Pittsburgh, and we should, having as big a cancer centers as we do, but we don't. So that's why it's wonderful to have you as a resource, because we certainly do have a lot of these issues of people, and
I'll reach out to some of my colleagues at UPMC and see if anyone has an interest in it. There may be, sometimes things are available, you just don't know about it, or there may be a resident graduating who wants to do it, and so I will reach out. That
would be great.
Yeah, even just have even someone to be a resource for us to send to that wants to. They may not have, because do you have additional schooling for this, or
no? Believe it or not, no. And the way that I trained for it is at Yale. There was a big cancer center, so you see lots of patients as a resident. And then my last year, the idea of me running this clinic, I basically just started seeing cancer patients once a week with one of my attendings, and I just saw them all. And after a year of doing it, I felt pretty comfortable in seeing most of the things. And now that I've been, I look relatively young, most say, but I've been doing it for several years now, 8 years as a doctor. So, you see things and you get that experience.
Absolutely. Are there the other larger cancer centers? Do they have this?
Yeah, a lot of them do. Sloan Kettering, Dana-Farber, Northwestern, Stanford, MD Anderson. These are my colleagues that I work with on clinical trials and I write papers with, and they have it. I think more and more cancer centers will have these types of onco dermatology clinics. It's a really great specialty in dermatology, and I suspect UPMC will have one soon.
Well, it is about looking at quality of life. That's one of, I've been doing this for 32 years, and the quality of life, is really important to people. We're getting quantity of life, which is awesome, right? But we need to focus still on the quality of life. So you provide such a great service for that, looking at something people don't even think would exist. So I think that's, a great thing that you're offering for sure,
Thanks, guys. I don't know Joseph Bikowski, Keith, but I will look up that name. Thanks, everyone. It was nice to be here.
Thank you so much.
Thank you so much.
Thanks, everybody.
You're welcome. I hope this was helpful. Take care. Have